Hey everyone, welcome to my Day in the Life series here on White Coats and Corgis. Most of you probably know me from Instagram or TikTok, where I make helpful free content for pre-meds and talk about my journey as a first-generation medical student. My mission here on YouTube is to give pre-med students all the information they need for a career in medicine. So in order to do that, I've teamed up with Med School Coach to create this series where I'm going to do a deep dive on each medical specialty. And I want to start off by saying that it can be really difficult to accumulate the number of shadowing hours you really need to be accepted into medical school. And especially nowadays, this can be really challenging. A lot of physicians aren't open to shadowing opportunities in person the way that they were before. So that is why Med School Coach decided to collaborate with over 20 doctors to give you a behind-the-scenes look at practically every specialty that you might be interested in. And this is all completely free. You can go to shadowing.medschoolcoach.com, register for the program, and then you get to choose whichever specialties you're interested in to shadow. At the end, you can fill out a short quiz, and then they'll give you a certificate of completion. That way you can count these hours on your medical school application.
I mentioned my mentor. One of his favorite quotes when people asked him about family medicine is he would say, well, we specialize in the skin and all of its contents. Basically what he was saying is the whole person is what we specialize in. And so I'm going to launch from that idea a little bit. So I had a patient one morning, typical morning. I went into the room. This was an 18-year-old college freshman. I walked in the room and said, good morning. I'm Dr. Bradshaw. Tell me what brings you in today. And he said, well, in the middle of the night, my roommate hit me on the arm, and he proceeded to hit me on the arm and said, dude, go to the doctor. And I thought that was kind of an interesting chief complaint. When we're taking history, we want to write down the reason that patient came in to see us. And so for him, it was, dude, go to the doctor. And so I've often reflected on that. What do we mean by that? Everyone's heard that phrase, you need to go to the doctor, or we're taking your grandmother to the doctor today, or I went to the doctor today. Most of the time, if that's an undifferentiated problem that hasn't been sorted out yet, that's going to be a primary care doctor, a family doctor. Could be anyone, could be anything. I'm going to touch on that here in the next slide or two. But think about all the reasons you can think of for why people go to the doctor. That's what we do. Now, oftentimes, of course, people will say, I'm taking grandmother to the cardiologist today, of course. And so that's going to the doctor. But the kind of the generic idea of going to the doctor means I don't know what's wrong and I need to find out what's wrong. And that's what family doctors do. We specialize in the whole person, the skin and its contents. We take all comers. One of the phrases that's popular is that we have a specialty of breadth rather than depth. Rather than being deep into one particular organ or particular organ system or particular focused area of practice, we specialize in a very, very broad range of things. And so it is a specialty, but it's a specialty of breadth rather than depth. And that requires a kind of a different kind of person, a different kind of personality. So not everybody's cut out for this sort of field. And we'll talk a little bit about those characteristics as we go. So here are people ask, well, what would a typical day look like for a family doctor? I put these in order of age, but this is not how it would go. You might get any of the next 2 pages worth of things on any given day. You might see a 2-week-old infant who's not nursing well. You might see a 6-month-old baby for a routine well child checkup. You might see a 3-year-old toddler who's got a Lego up his nose. You might see a 5-year-old for preschool physical immunizations, all of those things. You might see a 9-year-old who fell off his bike and mom thinks he has a broken collarbone. Could be a 14-year-old for a sports physical. I did more of those than you can imagine when I was in a small town practice. A 17-year-old for severe acne and ADHD and obesity, a whole lot to talk about. You might see a 25-year-old whose menstrual cycle is irregular, 40 down his leg, a 50-year-old with new onset headaches, is a cancer doctor. A 60-year-old with high blood pressure, high cholesterol, stress, who's a smoker and is having some chest pain. Maybe a 70-year-old with new onset weakness and hand tremors. An 80-year-old who's dizzy. That was always the bane of my existence when I was in private practice, because that could be anything. And boy, that's when you talk about an undifferentiated problem, dizziness is about as undifferentiated as it gets. Could be a 90-year-old who has cancer and needs to be put on hospice. So there's 2 pages of the kinds of things family doctors might do in a, quote, typical day. And again, not in order, not in clumps. You don't see all your 60-year-olds on the same day. You could go from the 60-year-old to the infant, to the toddler, back to the menstrual problem. And that could be the flow of a day. And oftentimes, at the beginning of the day, you don't know what that's going to be, which makes it fun, exciting, a lot of variation, but can also introduce a little stress if that kind of day is not your natural way of functioning.
Right.
So I like to joke that, there's one of the cool things about medicine is all the technology, and there really is some amazing stuff that people can use and procedures people can have and technology we have to offer. But for us, the basic tools of the trade are right here. You need a good pen, a good stethoscope, and an otoscope. And you can probably carry out much of your day with those 3 things. Grab me a white coat or not, and I can do most of those things I listed on those first 2 pages. So yeah, you can be a high-tech doctor, but you can also be sort of a low-tech doctor as well.
Right.
I'm going to talk about a little bit of the history. Some of this is just the history of medicine, but it will build into the history of family medicine, kind of how we got where we are. Like you asked, what are some things we've seen over the decades? People love this painting from 1891. This is what many of us think of as the old-time general practitioner, right? He's in the patient's home. Sick child, dad is in the shadows in the background, mom is bent over the table, in despair or concern or fear or whatever those emotions might be. And the doctor is thinking. And what I really love about this is he's not looking at his phone, he's not going to the internet, he's not pulling books off the shelves. He's sitting there thinking. He's drawing on all those things he's learned in his lifetime. About pathology and physiology and pharmacology and what's happening with this child and what else can I do. And so I think a lot of family doctors connect with this painting, because in many ways this is still what we do. We still are pulling it all together to try to solve a puzzle for a particular patient, but within the context of their family, their community, their culture, their situation. So in many ways, this in the last 130 years may not really have changed a whole lot in some ways. This is 100 years ago. Francis Peabody, who you may or may not have heard about in medical school, he was a Harvard Medical School professor, and he expressed some concerns back in the day, almost 100 years ago, concerned that modern medicine had fragmented the healthcare system. Now, if that doesn't sound familiar, you haven't been paying attention, because there's no question that here we are 100 years later and the healthcare system is very fragmented. One of his concerns was that we needed to have a return of the generalist physician, the ones who could deliver comprehensive, personalized care. And here's his quote, the one quote that I particularly chose for this. One of the essential qualities of the clinician is interest in humanity, for the secret of the care of the patient is in caring for the patient. And again, I'll illustrate that with the cases that I go through in a little bit, but it's huge, and it hasn't changed in 100 years. But here's what has changed. Back in the 1930s, kind of shortly after Francis Peabody, a little bit after the Flexner Report, and if you haven't heard about that, you probably ought to go and Flexner Report, but it what introduced modern medical education. And so in the 30s, about 80% of physicians were general practitioners. The other 20% were specialists of some sort. In the 1940s, you had an explosion of information technology. So you had an increase in specialization. You also had literal explosions in Europe and across the South Pacific, and that was World War II. And what was happening is there was so much knowledge to master that medical students started to feel more comfortable building a depth of knowledge in a particular specific organ system, or specialty. So this is kind of when specialties sort of really started to take the lead. World War II in particular, the military needed people with specialization and residency training. They needed surgeons, they needed anesthesiologists. And so they had a bit of an advantage. Your doctors who were general practitioners, they had done a 1-year rotating internship and they were sent to the front lines. And so there was a bit of a distinction in what kind of physician you were. The specialists would get higher rank, higher pay. They'd also probably be in hospitals away from the front lines. And so there was a little bit of a split happening right around that time. So in 1947, just a couple of years after the end of World War II, the American Academy of General Practice was founded. The idea was to look for common ground amongst general practitioners, who we are, how we have our identity as a part of medicine and the healthcare system. The 1950s, because of that, again, that exploding technology, you had a significant growth of specialties and therefore specialty residencies. There were few and almost none as far as general practice. You still did that 1-year rotating internship, and then you went out and you hung out your shingle and you practiced medicine. So that's kind of where things were in the 50s. The 60s brought along, as you know, a lot of social change in the 1960s. It affected everything in our culture, in our society, and particularly affected the practice of medicine. One of the interesting things was this increase of social consciousness. Again, this should sound familiar. We're sort of here again. This increase in social consciousness among young people. They were more idealistic. They believed strongly in the concept of personalized comprehensive care. So they saw that fragmented healthcare system and wanted to find solutions. In 1965, and again, this should sound familiar. We'll talk about this again with the Affordable Care Act. 1965, under LBJ, Medicare was passed into law. What Medicare did was it provided financing for people who qualified for the elderly to be able to get health care. So that was a funding thing. Insurance, Medicare is fundamentally an insurance program. Problem is, it didn't do anything about having more physicians available for all those people. So it's a great program. Medicare is a great idea, but people couldn't find a doctor to take care of them or their families. So in 1969, as a response to some of those pressures, and of course it's much more complicated, but in 1969, the American Board of Family Practice was created, and it's now the American Board of Family Medicine. It was the 20th Medical Specialty Board, and part of the whole idea was, let's have a clear idea of what is required to be this type of doctor. What's the body of knowledge you need to know? What are the skills you need to have? And they developed the 3-year residency program. So at this point, late 60s, early 70s, you started seeing the rise of family medicine residencies, 3-year programs intended to train doctors who were going to be generalists, but in specific areas. So the old rotating internship sort of went away. There's still a few transitional year type internships that people do if they're going into certain specialties. But basically that type of internship went away. And instead you had a 3-year training program to become a family physician. And so in the 1970s, you saw this growth of the specialty, growth of 3-year residency programs, clear board certification requirements. You had to complete a residency program. You had to take a certification exam. Family medicine was required, and you had to take the certification exam every 7 years, which I did, 4 times already. I've retaken my certification exam, which most fields don't have that. Yeah, it's a really interesting challenge. it's now every 10 years, but we did it every 7 for most of my career. And then there were ongoing continuing medical education requirements that you had to meet in order to continue to be board certified. And so that all developed in the 70s. In the 80s, you had kind of increasing establishment. Family medicine gained a foothold as a core component of the healthcare system. I put here, the 80s were also known for big hair and mixtapes. If you don't know what those are, you should learn a little history. I put a picture in of big hair and then I took it out. It was too distracting. But the 80s were a weird decade. But they were that was the decade that I was in medical training. So I started my pre-med and started those fall pre-med classes in 1982. Started med school in 84, started residency in 88, graduated from residency in 91. So I kind of missed the big hair and the mixtapes because I was busy at the hospital. The other interesting thing that happened in the 80s that I didn't put on here was AIDS. When I started my pre-med classes in 1982, we had not heard of AIDS. I was living in Houston at the time. In about 83, we started hearing about this weird syndrome that was happening San Francisco, New York, Houston. They called it the gay disease. I'm not going to get into all of that, but that was a totally different new paradigm for healthcare that happened during my educational period. I have one colleague that is an infectious disease specialist, and he started his fellowship training in the early 80s, and he said, I had no idea that I was choosing to become an AIDS doctor for most of my career. We just didn't know what to do with it, didn't know what it was, didn't know how to treat it. And of course, we still don't have an immunization. And I won't spend more time on that, but it was big. It was very, very big.
Yeah.
The 90s, you had the health maintenance organizations sort of starting to take a foothold. And one of the main concepts was what was called the gatekeeper model. The idea being we should funnel healthcare through primary care providers. So the primary care provider would be the gatekeeper to the system. Intellectually or philosophically, I think there's some reasonable argument for some of that. The concern was people go straight to specialists. They get a lot of high-tech care, a lot of money being spent. And it was basically reaction to the expensive healthcare. Is there some way to rein that in? And so they came up with this model. You can see I wrote boo and hiss. Nobody liked it except the HMOs. The patients hated it. The doctors hated it. The primary care doctors hated it. The specialists hated it. It just was a frustrating system. And I'll give you an example. In the early 90s, I had a new patient, picked me out of her list of doctors who could be her primary care doctor, just picked my name, came to see me, and she said, I have to see you to get 4 referrals. I want a dermatology referral for my acne and a gynecology referral for my birth control pills. And I forget what the other 2 were, but she wanted 4 referrals. And of course, I could take care of at least 3 of the 4 problems. I can't remember what the other 2 were, but certainly I can handle her birth control pills and her acne. But she wasn't interested in my being her doctor. She only wanted me to arrange her referrals. Well, that's not a healthy doctor-patient relationship, does not get you off to a good start, especially if you have to deny them. If you have to say, no, I can't give you a referral because doesn't really meet the criteria. So it made her uncomfortable. It made me uncomfortable. It was a horrible way of practicing medicine. The specialists hated it because people couldn't come directly to them. It was just frustrating for everybody. One of my interests is headaches. I actually don't think, I like taking care of people with headaches, and I don't think that most people who have headaches need to see a neurologist, but most people who are getting headaches want to see a neurologist. Yep. And I have no reason to stop them from seeing their neurologist. I know what's going to happen. And I know that often they're going to wind up seeing me again, because it's hard to get an appointment. You wait months and months. You can't get a follow-up appointment for months and months. And people who need to see specialists can see specialists. People who will fit better with the family doctor will wind up back with the family doctor. So in the 2000s, we saw lots and lots of changes. Technology, I talked about the smartphone and the internet, but seriously, in the mid 90s, when I was teaching at the med school, I had a desktop PC, but not my own printer. Didn't have a cell phone yet. We had one cell phone for our entire department, so whoever was on call got the cell phone for the night. So that was mid 90s. And so 2000s, think about the explosion of technology, changes in healthcare. But again, we got those concerns that we can trace back to Francis Peabody. We have a fragmented healthcare system. There are a lot of financial pressures. Healthcare costs just keeps growing and growing and growing. And so in 2010, we saw the Affordable Care Act. It's in some sense 1965 all over again. There's increased financing to help people get insurance, but they can't find doctors. There just aren't enough family doctors to go around. Yeah. So you can get insurance, but good luck finding a doctor who, and it's not because they don't want your particular insurance, it's just because they already are full. So we're kind of back where we were in 1965, which is great. We're finding ways to get people who don't have insurance, the uninsured, we're finding ways to get them funding, but we're not providing any more actual healthcare service. It's not available. And so again, when you roll in COVID-19 into this situation, it's just created major turmoil. So that's where we are. The future of family medicine, this is interesting, and I'm not going to read all this slide, but there's a number of people meeting from various areas that have stakeholders in family medicine doctors, government, insurance, other kinds of providers, normal people who are interested on the patient side, looking at, okay, what do we need to do to respond to all these changes in healthcare to strengthen family medicine as a specialty, just like we did in 1969. This is a brand new initiative, and I think it's very exciting. It's a time of saying, okay, we've done well for 50 years, but it's time to reassess what it's going to look like as we go forward. And I think that's great. I think it's fantastic. So here's a group of very happy family medicine residents. I'm guessing this is on June 30th, before they start their residency on July 1st, because look how happy, rested, smiling they all are. But this is, these are just a nice looking group of folks that are actually in a family medicine residency. Okay, so let's talk a little bit about the core values of family medicine. I think you'll connect with these no matter what specialty you're in, but these are particularly important to us. You can't have a medical presentation without an Osler quote. So here's Sir William Osler. It is much more important to know what sort of patient has a disease than what sort of disease a patient has. And so we like to know our patients. The first thing I listed is caring. Family physicians don't just care for patients or diseases, they care for people. It could be dizziness or nausea or a headache or meltdowns. College students and meltdowns like that could be anything. Panic attacks. It's very hard to distinguish when someone comes in with an undifferentiated problem. So if your personality doesn't lend itself to that, family medicine could be a real challenge for you. We like to know the context, the biology, the psychology, the social situation. So that's why we call it the biopsychosocial model. It's kind of an old term, but it still is useful in showing that we're looking at the whole patient in their whole context. We value community. It helps to know what community you're in, what's going on in the community. When I practiced on the Mississippi Gulf Coast and they passed casino gambling, it totally changed the community. And believe it or not, it changed the healthcare of the community in a couple of interesting ways. One was people working for casinos had great insurance, which they didn't have before. So there was a whole lot more access to care for people who previously had worked jobs where they didn't have insurance. But there was also a lot of people losing their weekly paychecks down at the casinos. And so the amount of anxiety, depression, financial pressures exploded. I actually took care of a dealer. She had loved her job. She had got paid well. She made good money and good benefits. And she said, I'm depressed because I'm taking these people's money all day long, and I know they can't afford it. So you got to know your community. That's the whole that example. It matters. And of course, clinical skills. Sometimes people think, well, family doctors don't have the clinical skills. Well, no, we do. And I can talk about that more and kind of how that compares to other doctors and how it compares to mid-levels. And if we want to get into that a little bit later, I think there'll be a chance for that. But you've got to be a very skilled, clinically skilled doctor to be a good family doctor. So here's a little bit on the personalized comprehensive care. I listed 4 things here. First contact into the system, right? Again, grandma fell. We don't know why she fell. We're going to take her to, quote, the doctor. And that's your first entry into the system. And, where we go with grandma will depend on a whole variety of things that happen as we take care of her. Continuity care. You take care of people when they're healthy, when they're sick, over time. And as I said at the beginning, that's one of my things, is knowing people over time, being in relationship with them over time. Comprehensive care. I know a little bit about a lot of things. That's intimidating for some people. If you do go to a good medical school, a residency program, you're quite capable of doing this. One of the things I loved coming out of my residency program, which was a very strong residency program, is I felt equipped to do any kind of family medicine, emergency medicine, urgent care, rural medicine. I could deliver babies if I wanted to. I was prepared for all of it. Coordination of care, again, people get lost in the healthcare system. I get plenty of phone calls from friends, neighbors, like, I don't know what to do. I went to the ER and they did this, but then they told me to follow up, and I don't know how to do that. I don't know where to go or what to do. That's part of what we do, is help advocate for the patient in the system, help them move through the system, help them know where to go, what specialist to see, when to go to the hospital, when to go to the urgent care, when it can wait. And those are important. Those are important things.
Right.
So if you're a medical student and you're thinking, hey, this might be interesting to me, here's my advice. First and second years, and this is going to sound redundant, learn as much as you can about everything. Just be open to learning. If there's a student family medicine interest group on campus, join that. It doesn't commit you to family medicine, but it can expose you to some. Join the American Academy of Family Physicians in your state chapter. They have a lot of great resources. They have scholarships. If you think that's an area you might want to go into, those are great, and they're very cheap. I think the student memberships are very, very inexpensive. I recommend some volunteering and shadowing. Again, if you get a little break, I did this over Christmas break, maybe just a day or two with a family doctor. Say, hey, what are you doing? Can I come hang out with you for a few hours this morning or whatever? You'll see a lot and you'll learn a lot. Third year, you're overwhelmed, so just learn as much as you can about everything. Experience all the rotations. I loved a variety of my rotations. As I went through my third year, I considered endocrinology because I had a great experience there. Then I thought about anesthesiology. Then I thought about neurology. Then I thought about urology. And I went, by the time I got to the end of third year, I had sort of looked at half a dozen different specialties that I found very, very interesting. Mm-hmm. Fourth year, I put in here, consider a family medicine elective away from the medical school environment so you can see what real family doctors do out in the community. And this was a turning point for me. My fourth year, one of my first electives was an internal medicine elective. And again, this is just my personality, but it just didn't work for me. They're really complex patients and worrying about blood gases and renal function and et cetera, on everybody. I found that sort of just draining. I went away to a community family medicine residency program, spent a month there, absolutely loved it. As a student myself, I saw 4 or 5 patients in a half day. Then I would check out with the attending, we'd go over things, and I might see, like I said before, I might see a baby, then an old lady, then middle-aged person and a teenager. And I did all of that as a fourth year. Could be skin problem, could be vomiting, could be shortness of breath, whatever. And so I came home from that month, basically had completed the full circle. This is what I want to do. That was to me just, that's part of the experience of being away from the medical school and experiencing family medicine in a different setting. So we'll talk a little bit about residency training. One of the most important things that's unique about family medicine training is the continuity clinic. From the day you start, July 1, you have an assigned patient panel. As an intern, it's not a very big panel, probably just a couple hundred patients, but they are your patients, and they'll be your patients for the whole 3 years. You have 1/2 day a week, usually as an intern, 1/2 day a week where you go to clinic and you see your patients. And it's pretty cool because you don't really get to do that in other specialties very much, if at all. As you go through your training, that amount of time increases and you have more responsibility, you have more patients. So by your third year, you may be spending, depending on your rotation, you might be spending 4 or 5 half days in your clinic seeing your patients. And so you are becoming a family physician from day one. And it's neat because if they get pregnant, you take care of them during their pregnancy. If they have the baby, then you take care of the baby too. If they go in the hospital, you might go deliver that baby. If an older person goes in the hospital, you go see them and make rounds on them, just like if you were their family doctor. And that's a really, really neat part of family medicine training. The other part is you do certain number of inpatient rotations. Again, first year is very heavy on inpatient rotations. So you do adult medicine, which includes the ICU. You do pediatrics, various surgery rotations, labor and delivery, newborn nursery, cardiology, pulmonology. You do emergency medicine, you get geriatrics, all of those things. But no matter which one you're doing, you still have that half day where you go over to your clinic and see your patients. If you're at a teaching hospital, like when I was at Southwestern Medical School, Parkland was our teaching hospital, our family medicine residents did their adult medicine with internal medicine. We also had a family medicine service where they saw us, the faculty in family medicine, take care of our own inpatients. But their internal medicine experience was with the internist. If you're at a community hospital, it may only be a family medicine service run by your own faculty. So there's one thing to be thinking about if you're looking at residencies, kind of what the flavor of that is and what appeals to you. You also will do an outpatient rotations in things like ENT, ophthalmology, dermatology, neurology. Those are wonderful experiences. Again, you're just basically working side by side with the specialists in those fields. One other element that's unique to family medicine is health system management. We used to call it practice management. It was preparing residents to go out and run their own practice. So we were teaching them about billing and coding and hiring staff and contracts and so on. Since most people now work in employed situations, this is it's a little more focused on what it's like to be part of a doctor in a bigger system. And then, of course, you have electives. The further along you get, the more electives you can do. All right, so some highlights here. There are more than 600 family medicine residency programs in the United States, and no two programs are exactly alike. Some are very competitive. People don't realize this. There's sort of this idea, well, if you can't do anything else, you can always do family medicine. There's some truth to that. There are programs that are easy to get into, but there are some that are very, very competitive. My program, we took 8 residents a year. The year after my group, 5 of those were AOA in their med schools. So it was a competitive program, hundreds and hundreds of applicants for those 8 slots. An important consideration, which I just touched on, is whether to train in an academic health center or a community program, advantages and disadvantages to each of those. I trained in a community program, but I taught in an academic health center program. Both have their strengths. Both have some areas that, maybe they don't do as well. One of the things I like to talk about, and this is just really hard to pin down, is what I call the touchy-feely programs versus the ruggedly independent programs. I interviewed one resident where I felt like, let's go to the ICU, put in central line all day today. raw, we're going to do everything. And then other programs where they were more concerned about whether our moms were breastfeeding and teaching moms how to nurse their babies and things, which is all good stuff. But it just sort of depends on kind of what appeals to you, what kind of feel you want to get. Believe it or not, there is fellowship training in family medicine. Typically, that's 1 year after you finish your 3 years. You can do addiction medicine. You can do a faculty development fellowship, which I did. You could do geriatrics. You could do headaches. You could do informatics. You can do an OB fellowship, et cetera. Sports medicine is very, very popular. And so you can have your areas of interest and do some extra time to explore those areas of interest. And so you can narrow it down a little bit if that's appealing to you. Career opportunities, I always told my students and residents, it's a U.S. map, close your eyes, throw a dart at it, and I guarantee you they need a family doctor. There just isn't anywhere where family doctors aren't needed. It's the most recruited of all the medical specialties. You can find that from the physician recruitment firms, Merritt Hawkins and groups like that. Always in high demand. One of the nice things is it doesn't take a big population to keep a family doctor busy. The numbers are 2,000 to 2,500 people is enough to keep a family doctor busy. Whereas certain specialties, that might be 10,000 or 20,000. If you're a brain surgeon. Yeah. And so you can go just about anywhere. If you want to live in a ski community in Colorado, I had a colleague who lived in Telluride for a little while. She just took care of the rich and famous when they went skiing. You can do that. So you can go anywhere. And because of that, you can really affect your lifestyle, how much you want to work, how much you want to earn, all those things. So you can do office practice, you can hospital-based, nursing homes, urgent care, emergency departments, academic medicine. You can do rural or urban. You can do international. You can get into leadership, military branches. I know one guy who worked for the State Department who lived all over the world and took care of our State Department employees. Had fascinating stories. Of course, the VA locum tenens is always an option. A friend of mine, when people ask him, what's the difference between the lifestyle for family medicine and other specialties, his answer, tongue in cheek, his answer is, it's the difference between a 3 series and a 7 series. What he's talking about is BMW. What his point is either way, you're driving a BMW. I always liked it. People say, well, you can make a lot more money in a lot of other specialties. That's absolutely true. You can make a whole lot more money, but you can be pretty content driving a 3 series as much as a 7 series. So that's kind of his way of describing it. I've always thought that was kind of nice. Depends on what kind of lifestyle you want to live, but you're going, you're gonna have a very comfortable lifestyle as a family doctor. You can drive your work hours, your schedule, your family time. I have colleagues that while they were young moms, they worked 1 or 2 days a week, and then as their kids got older, they went back to a bigger schedule, more full schedule. You can do that in family medicine. So there's so many different ways of practicing family medicine, and you can make a very nice living doing that. So what I want to do to illustrate what the life of a family doctor is like is describe one family that I took care of. These are true stories. This is all true. I changed the names, changed the pictures, but the stories are fundamentally all accurate. So I want to introduce you to Barbie and her 2 children. Barbie is a 52-year-old widow. Her first husband was a doctor. He passed away. Actually, I don't remember how. She's going through menopause and also having some anxiety and depression. A colleague of hers at work referred her to me, said, you need a good family doctor, go see my doctor. And so she did. She set up an appointment and came in. She has 2 kids. Jack is 17. He's generally in good health. Very smart, excels in school. Lucy is 15, and she has migraine headaches. And so that was the core family. They became my patients. I took care of them over a period of actually years. Some basic clinical questions that we addressed for them. Barbie, what can I do about my menopausal symptoms? Is it safe to take hormone replacement therapy? Do I need medicine for my anxiety? Are there other options besides medicine? What else can I do to take care of these things? For Jack, can I get a football physical? I want to play football. By the way, do you screen for cardiomyopathy? Because he had a smartphone, and he looked up what a football physical should involve. So he wanted to know how we screen for cardiomyopathy. Lucy, what should I do when I get a bad migraine during school? Is there anything I can do to prevent the migraines? How can I get my teachers to understand that I'm not faking it or being lazy? This is typical family medicine. These are the kind of things we do. I would give you all the answers to those questions, but we need to keep moving. But there are things that's stuff that you do. Well, Barbie got married. Her first husband died, as I mentioned, so she met Ken. And Ken was her new husband. He had a different doctor. He's 48. He's a little bit overweight, had high cholesterol, high blood pressure, a really stressful career. Thankfully, he was not a smoker because that's a lot of risk factors for heart disease. He was switching doctors at the urging of his wife. And so he came to see me. His first visit was because he had cough and shortness of breath. He had recently been diagnosed with pneumonia, started on antibiotics, but was not getting better. So that's why he was there to see me. So let's talk about Ken's cough and shortness of breath. The first thing you do absolutely always is start with a thorough history and physical. Some highlights from that: the duration of his symptoms, about a week. Did he have fever, chills? Was he coughing up sputum? The answer was no. Odd for pneumonia. Did he have any previous respiratory problems? Asthma, chronic obstructive pulmonary disease? No prior respiratory problems. Any underlying health issues? Well, we already talked about those, his blood pressure, his cholesterol, and so on. I did a lung exam, and I heard fluid bubbling at both of the bases of his lungs. So the question is this pneumonia? What do we do next? Well, I was suspicious that this wasn't pneumonia. It didn't sound right to me. Just didn't quite fit. I was more concerned that this could be congestive heart failure. I ordered a chest x-ray, got it right then. And sure enough, the x-ray showed that he was in congestive heart failure. I put Ken in the hospital so that we could treat his congestive heart failure, get some further evaluation. But the real interesting problem with Ken is, why is this 48-year-old guy in heart failure? And there are a number of things that can cause that. Turned out for Ken, he'd had a silent MI. He'd had a heart attack and didn't know it. And so his heart wasn't functioning properly. And so there you go. There's a day in the life of a family doctor. Take care of Barbie and her kids and her new husband, Ken. And all of a sudden, I've got him in the hospital getting, fairly emergent treatment for heart failure and a heart attack that he didn't know he had. Did well and continued to be my patient. Then I met Barbie's parents. Meet the grandparents, right? So her parents were in the same general vicinity, and she insisted they come see me too. And so I called them Luke and Laura here. Luke's 77, has osteoarthritis, just worn out knees, AFib, a hand tremor. He likes to walk. He walks 2 miles every day. He loves butter pecan ice cream. Laura is 75. She's got osteoporosis, high thyroid, and mild type 2 diabetes, all fairly well controlled. Luke and Laura are very active in their community. They love their grandchildren, and they like to watch General Hospital every afternoon. So I see them for routine visits every 3 months, roughly. And so now I'm taking care of the grandparents, the mom, the new dad, and the 2 teenagers. They're all now my patients. That's family medicine. So we'll catch up with Luke and Laura in a little bit. But for now, something tragic happens. So Jack's at football practice, and after practice, they're horsing around. Another football player grabs him around the neck, puts him in a headlock, and they're just horsing around. He's not wanting to hurt him, but Jack passes out, starts turning blue. The other kids say, "Hey, let him go. He's turning blue." So the guy lets him go. Well, unfortunately, no one catches him, and he falls and he rolls down a flight of stairs. He sustains a major closed head injury. He's in a coma. He's got facial fractures, multiple other injuries. One of my partners is on call that night, so he gets Jack admitted to the intensive care unit at our hospital. He gets everybody involved, right? He's got a neurosurgeon, neurologist, a pulmonologist to manage his ventilator, a nephrologist because his kidney function's acting up. He's got the ENT for his broken facial bones, orthopedist for some other bone injuries. All these specialists are taking care of Jack, right? So this morning, I get there and I head to the ICU to make rounds to see Jack. I review all the notes, which, by the way, with all those specialists, took me a very long time to read everybody's notes, to review his medical chart, to talk to the nurses, to see what all is going on. And of course, at the moment, I'm feeling like, okay, so I'm Jack's family doctor. What do I really have to contribute here while he's in the intensive care unit, right? It's just a fleeting thought. Well, what do? I do what my medical student saw when she went and visited the community residency program. I head for the door, not the door out of the ICU to the cafeteria or to the break room, but I head through the door into the waiting room. I go into the waiting room. The whole family's there. As soon as they see me, they stand up, come to me. It's one of the high points of my career. I walk in, they all come over. I say, "How are you all doing?" The granddad gives me the biggest, tightest hug and says, "Much better now that you're here." And I realized at that moment, that's what family doctors do. Finally, at the end of his hospitalization, it was just the neurologist and me. And we were there to then navigate Jack through the future, his rehab, figuring out what to do about his schoolwork, rehab for his physical problems as well as his brain. He did graduate from high school. Unfortunately, he never really recovered his full intellectual function. He went to a small college, graduated from there, but really wasn't able to go to medical school. So life-changing event that I lived through with his family. So that's two stories. I took care of Ken and his heart failure, took care of Jack and his. So I'm going to wrap up real quick. I borrowed this from the emergency medicine talk because it applies just as well. How do you choose a specialty? My picture is somebody about to cross a rickety wooden bridge over a deep river gorge. It's got to fit your personality. You got to decide between whether you want to do general medicine or something specialized. You want to take into account all of your areas of interest. This is important. You want to ignore the gossip and the commentary from outside the specialty. Don't buy it that people understand what the specialty is that you're looking at. But once you've decided, commit to that specialty, and that becomes who you are. So back to the beginning, dude, go to the doctor. Couldn't help this. It's a little cheesy, right? But can you imagine your photo there? Could you imagine having and say, dude, go to the doctor? It's pretty cool, actually, to take care of the skin and all its contents.